So here's a handy chart. You can determine by answering the questions what type of formula you're going to be giving the patient. Okay. Safe handling protocols, once again, that's a nursing responsibility. The HACCP system is in full force here. Okay, so you have open feeding systems. The formula is transferred from the original packing to a feeding container, opens up a can of worms in terms of contamination. I have to be very, very careful here. Closed feeding is safer. The original packing is used, it's hung from the tube, and it really does cut down the chance of contamination. However, of course, it's much more expensive. So at the nursing station, the nurses are washing their hands. They're washing the container that the formula is in, okay, with alcohol. They are promptly refrigerating any kind of leftovers that's going to be date and time stamped, okay, with an accompanying date and time that it is to be discarded if it is not used. This is something really important. It's when you're dealing with kitchens and leftover foods of any kind, not just tube feedings, but any kind of leftovers. You have to have a beginning date, in other words, when it was put into the refrigerator, and the end date, when it must be discarded. Without that, you run the risk of getting fined by various organizations that come in and check things out. Okay, so at the bedside, we want to reduce the risk of a bacterial infection, so maybe we're going to hang that, or the nurse is going to hang that formula for 4 to 8 hours. Contamination is definitely going to occur if it's hanging there for longer than that. And change the feeding container and the tubing every 24 hours for a closed system. Okay, so initiating and processing an x-ray is going to determine if the tube is actually in the right place, and then checking the fluid pH, which is important also because we know that the stomach has a lower pH than the surrounding organs and tissues. Formula delivery methods, intermittent, 250, 400 milliliters of formula is delivered over a 30 to 45 minute time frame. This is very similar to a regular eating pattern, right? But it could be difficult to tolerate, and the risk of aspiration is high. Continuous feeding, that's 8 to 24 hours, or bolus feeding, so that's the third one. That is when a rapid delivery of a large amount of formula to the patient. It's convenient for the patient and the staff. However, it could result in abdominal discomfort, nausea, cramping, and once again, the aspiration risk is high. So nurse is going to measure the gastric residue volume. In other words, what was not absorbed by the patient. And if it's 500 milliliters or more, then they're going to stop the tube feeding and they're going to find out what's going on. Okay, there's a reason for that. Okay, meeting water needs. Okay, so those needs are going to vary, right? About 2 quarts a day, but it could go more than that if a patient is having severe nausea or vomiting. If the patient needs additional water, okay, due to thirst, dehydration, the patient can be given it unless it's contraindicated. In other words, the patient is having some other problems, or maybe they have edema or something like that, and so the doctor has said, no, we're not going to give them any more water. Okay, so dehydration, we're going to evaluate, are there any weight changes? Is the patient losing weight? Fluid intake versus outtake, okay? The nurse is going to be monitoring that, so you're going to see if the patient is letting go of more fluids than taken in, then that could be a sign of dehydration. The BUN, creatinine, and sodium levels are high. That usually indicates that there is some sort of dehydration going on. Okay, formula water content is usually to 68 to 85%. That would be 680 to 850 milliliters. There's water flushes as well, okay, to prevent clogging. So that's done 4 times a day. So there is definitely water for this patient. There are potential diet-drug interactions. We want to be very careful. We may stop a tube feeding, or the tube feeding may be stopped in order to permit the drug to be given, because some drugs work on different stomach environments, acidic, or they may need alkaline or whatever. So they're going to probably stop the tube feedings. And the diarrhea, okay, could come about through the drugs. And you want to be able to isolate it out and say that that is actually what is the cause. Okay, so complications. Frequent occurrence is going to be all of these: diarrhea, constipation, impaired gastric motility. Okay, the are things going through the gastrointestinal tract, abdominal discomfort, nausea, vomiting. There could be problems with the actual tubes or the pump itself, metabolic complications, over underhydration, electrolyte imbalance, hyperglycemia. Even if that person is not a diabetic, that could be happening. So we're going to be monitoring the tube feedings, okay? And here's a really good chart for that. And last, our last slide for this particular chapter, tapering off the formula. Okay, so there's going to be a gradual shift to an oral diet, right? So if the patient is on continuous feed, we're going to go to intermittent, right? If they're on an elemental formula, we want to go to a standard formula. So oral intake should supply about 2/3 of the estimated needs before tube feedings are discontinued. That is a magic number, my friends, so remember that. Okay, thanks so much. Bye.